a second? Second by Amanda. You got that? You helping her out over there? Yes. Okay. Any discussion about them? All in favor, please say aye. Those opposed, same sign. Performance improvement reports. Doesn't require any action. Patient experience update. Good afternoon.
Hi, I brought a friend with me today.
You want to introduce?
Brought a friend with me today.
Rob, do you know Amanda and Zim Zimmerman?
I do not.
Okay. Why don't you introduce yourself?
Yeah, so I guess I should turn this on for posterity, right? So I'm Rob Stevenson, and I'm just a little bit less than a month into tenure as interim Chief Quality Officer of this organization. Previously, I've been a surgeon here for almost 15 years. For the last year and a half, I have also served as Vice Chief of Surgery for Quality, Safety, and Patient Experience under Acclaim. And I still hold that title as I'm in this interim role. And so I'm still doing some experience stuff. And the one thing I will say about experience that we're telling really communicating to our physicians is that experience isn't about making patients happy. I mean, although we certainly want our patients to be happy, and that's a great thing to want to go for. But the thing we're telling our physicians now is that experience, and especially the way we're measuring it, is a predicate for quality. So it's a very reasonable and tight partnership between experience and quality that will ultimately drive these results for our patients. So I'm going to turn it over to Laura to lead off this part of the presentation. Then we have some interesting things to share with you as well.
And I think it's really an important piece to the puzzle is that our team as a whole really realizes and recognizes that patient experience does lead to better quality outcomes. And when we can get that across and when that understanding is very clear, it becomes a very different way of looking at it rather than just it's a smile survey, because there's not one question on the survey that asks about are our patients happy or do they smile while they're do they smile while they're here. So that being said, we'll hop into the slides. This is the most current update. We do update our dashboards on the 20th of every month. The data is lagging a little bit, and so this is the most recent information from really the closed out month is February, meaning we still have been receiving surveys in, but those months are not closed. So currently, fiscal year to date, our inpatient dimensions of care that we are moving at a national average rate of improvement. There are 4 out of the 10 that we are moving at that, again, national average rate of improvement. That's really important for the board to understand because our inpatient units function at a very high level. And so it would be similar to an athlete, a very physically trained athlete who is trying to lose more weight or become more fit, and it's harder. It's harder. And so and we'll look at the specifics of the inpatient unit in a moment, but this team is doing a lot of work around trying to make sure that we're taking great care of our patients, again, leading to quality outcomes. On the outpatient side, instead of national average rate of improvement, we elected to move each one of the questions by 0.3, and that was designed by our vendor. And so 7 out of the 10 questions are moving 0.3 or greater at this point in time. As a reminder of what the dimensions and the questions are, we've added that to your slide deck. The dark blue lines on this slide have to do with the dimensions of care. Those are the 10 dimensions. There are questions under each of those dimensions. So for instance, under care transitions, the question is, during your hospital stay, staff took my preferences and those of my family or caregiver into account in deciding when my healthcare needs would be, my healthcare needs would be met when I left. When I left the hospital, I had a good understanding of things I was responsible for in managing my care, and when I left the hospital, I clearly understood the purpose of my taking each medication. I'm not going to read all of these to you, but they all follow that same vein, which is all around how often did particular elements of care happen during the patient's stay. And that's really different than the way that we used to measure a few years ago. So again, of these dimensions, what we're seeing is 4 out of these 10 dimensions move. So we've moved those questions and a national average rate of improvement. There's an important thing to mention though here. When you look at communication about medications, communication about pain, communication with doctors, communication with nurses, discharge information, and the overall rating of the hospital, all of those dimensions have moved up since last year, even though the communication with nurses dimension is down by 0.3, it has moved up over last year. It just has not moved up at the national average rate of improvement. Again, realizing and recognizing that that dimension performed at a very high level. Make sense so far?
So far, so good.
So far, so good. When it comes to the outpatient world, 7 out of 10 of our questions, there are not dimensions in this world, there are only questions. This is a real-time survey that is done right after the patient leaves the clinic. And questions are, again, very similar to what they are on the inpatient side, and 7 of those 10 questions are moving 0.3 or greater. And what I think is really important to mention on the outpatient side is we've been working a lot, as Rob mentioned, and this is part of why I think it's important that we're here together. We've been working a lot on provider communication and the elements thereof, and every one of our questions that are related directly to the provider on the outpatient side is actually moving up over last year. So that's an incredible amount of work and a very heavy lift that has taken place this past year to make sure that our physicians really understand the survey and can actually perform their behaviors based on what the survey is actually measuring, because that's what's important to patients. Questions on that?
Nope. Anybody?
Okay. So what have we done differently this year? So far, what we have done is established an executive steering team committee. We met for a long time every week. We now meet every 2 weeks. And during that meeting, the attendees report out on the work that they're doing as it relates to the either dimension of care or the questions. So whether they're on the inpatient or outpatient side, we talk about what is happening in their areas. Teaching and observations are still occurring. So all of our tower nurses and techs have gone through a training on keywords at key times and hourly rounding. Hourly rounding is a tactic that we use here at the hospital to help not only our patients but also our nurses with efficiencies. And so it really covers 4 specific areas that the nurses go through every hour, or the techs go through every hour with our inpatients, and it covers, do the patients need to use the restroom? Are they in pain? Do they have their possessions where they need to be? And are they positioned appropriately so that we eliminate any type of bed sores? So they've all gone through that training, and those are being observed and checked off at this point in time. Even up as recent as Monday, when I was doing rounds on one of the floors, one of the nurse managers was actually doing observations with her nursing team. So those are actively happening. The same training now is happening with critical care. It's just not quite completed, but it is in the process and should be completed very quickly. We have also completed training with all of our PARs in the clinics on keywords at key times and how to greet our patients in a way that makes them feel welcomed. And we are beginning behavioral health in the emergency department now. EVS is also going through specific training in patient experience. And then 2 times per month, we have all of our new nurses and any clinician that is struggling with any of the tactics that are related to any of the questions or dimensions that we have here. They go through 2 times a month. We actually offer HCAPS University, and so they can come back through, and that's a longer training. It's a much more detailed training. And then this month, we're beginning Close the Gap in the clinics, and that technique is about when you're a patient and you're waiting in the clinic and someone opens the door and yells your name and then waits for you to walk to the door. Have you all ever been through that experience where they sort of yell at you and then you get up and try to find who's yelling so that you can go to the back? Not that that would ever happen here. But Close the Gap is where we actually meet the patient where they are. So we walk over to where they are in the waiting area and we walk with them and we begin our aided and we begin our introductions of what that particular visit might look like. And that's actually being done as a train the trainer module. Any questions on any of that?
Anybody?
Okay. Rob, do you want to talk about the dyad? We're creating this other really neat concept and product here, and so Rob and I have worked directly on it, and so I'd love for him to talk with you about that.
So the missing piece, you know, our employees here are so engaged, and they have been on board with where we need to go for our patients for a long time, and that's been reflected in some pretty outstanding scores, particularly on the inpatient side, for quite a while. And even though we are only at 4 dimensions improved on the inpatient side, the baseline is really, really high on the inpatient side, so it's a little bit harder to push those up. So the missing piece has been our providers. And one of the things that's happened over the last couple of years is that our providers have become more engaged and more interested in engaging with us to drive forward improvements in all kinds of different aspects of care, whether it's quality, whether it's safety, and now experience.
Rob,
yes, sir.
Define providers for me.
So provider includes physicians and advanced practice professionals of various kinds. So we use that collective term to refer to that entire group of people, and that way we're not separating out physicians from our outstanding APP colleagues. Okay. So Laura and I did quite a bit of sorry, I'm away from the microphone. Did quite a bit of brainstorming about how we might bring our providers together with our other team members to really drive forward improvements in experience and thereby drive forward improvements in quality, as these experience dimensions, as I've said, are predicates of quality. So what we've done is create across the network a whole series of dyad relationships, dyad partnerships between key physician leader types. They don't have to have a title, but they have to have some leadership chops, and key nursing leaders on the inpatient side, and then perhaps in a slightly more complicated relationship on the ambulatory side between clinic managers, nursing leaders, and providers. So I've been responsible for creating the inpatient side of this, and we've basically partnered all of our nursing directors with dyad partner physicians, and then down to the unit level, every single unit manager now has a dyad partner physician, and they happen to be all physicians at this point for those relationships. What I expect from all these people on the inpatient side is to attend as often as they can the staff meetings of these nursing units to talk about experience, quality, and safety issues, to meet with their nurse manager at least once a month, and to do rounds for experience with our patients on these various units at least once a month. So those are the expectations for what we want to see from them in terms of that work product. And then what we've done in addition to that is we are in the process of developing a pretty phenomenal mastery program in patient experience where, and you can see the different things on this screen, you can see the different subject areas that we're going to be covering. This is going to launch in June with sort of a recognition event, and then follow along with educational sessions in all these areas. The goal of the sessions is to have a fairly short didactic piece, and then a longer experiential piece or practical piece where we practice these techniques together. And then at the end, they'll have a graduation and receive a mastery certification in this area. In addition to that, and I'll let Laura go on to this, is this is now getting integrated with our Practicing Excellence curriculum, which is a which is a program we've been involved with, as probably many of you know, for the last year and a half or a couple of years, which is Steve Beeson's program, which originated out of San Diego. But I'll let Laura talk about that part of it.
So for those of you who've been on the board, if you recall, we were selected as a pilot unit for Practicing Excellence, which is a physician-led curriculum by physicians for physicians. And we have been actively utilizing that particular platform for the last year and a half or 2 years. We currently have monthly provider forums, and we end up with right around 50 people in each of those sessions. They are physician-led, so our physicians are actually leading those sessions. And the Practicing Excellence has created a certification program that fits really nicely within this mastery program. And so at the end of this, not only would these physicians walk away with a certification from JPS, but they would also walk away with a certification from Practicing Excellence, which will be a nationally recognized certification. Both sides will offer CME credits, so they'll be able to get CMEs as well as just really enhance their skill set in the way that we care for patients. And that is across the network. So that will be, what you see on your next slide are actually those individuals who have agreed to do this on the inpatient side. And then we are actively recruiting on the clinic side and have not quite finalized that list yet, but this is scheduled to launch. First session will be toward the end of June.
So what we're hoping from this ultimately is to do something in experience and quality and safety ultimately as well, that's something akin to what happened with the TCU cohorts, which is to create a group of highly engaged people who really understand the fundamentals of these areas in a deep way and can begin to communicate that not only just in their own work, but also to their colleagues, and sort of raise the level of conversation, much like those TCU cohorts raise the level of just sort of general engagement conversation across the providers of this organization. And so that has been very impactful, and I suspect that this will be also. The amount of excitement around these invitations I think says a lot about how engaged this particular inaugural group will be. And so we're very excited to get this going.
What questions can we answer for you regarding patient experience? Yes?
I've got a question for you. I normally wait until the presentation's over before asking questions, because a lot of times you get answered in my way.
Sure.
Do not understand the transition from your digital numbers here to your 4 out of 10. How does that,
Sure.
how do those translate over?
Yeah, so if you're looking at the inpatient dashboard, on the left-hand column, you see the dimensions of care. Those dimensions encompass the questions that are on this sheet here. So each of the blue lines is a dimension of care that CMS has determined is important for us to measure our patient experience by. So their care transitions, communication with nurses, communication about medications, discharge information, communication with doctors, cleanliness and quietness of the hospital, communication about pain and responsiveness of hospital staff. In addition to that, there's an overall rating and a likelihood to recommend dimension as well. So those dimensions, there are 10 of those, and our goal was written around moving a target of 5 of those dimensions, the national average rate of improvement for the year.
So the number represents the 10 categories.
The number 4 represents the number of categories that we have moved the average rate of improvement nationally.
Last year, what were you?
Well, in what respect?
What were you, a 4 last year?
Well, we didn't measure it this way last year, actually.
Okay, so
We
this is the
only
first
went
year
by
you're doing
one
this?
question. Yes, the last several years, we've actually only used as our organizational goal the overall rating of care. We have always measured all of these questions, but that's the only one that we actually brought up to the board.
And are other hospitals measuring themselves the same way?
Other hospitals measure themselves this way and many other ways. There isn't a national agreement as to which way is the best way to measure.
So there's no way we can compare what we're doing with regard to what other hospitals are doing?
Yes, we actually can.
Okay.
So we can measure it at a deeper level. So Every one of these numbers that you see here correlates to a percentile ranking, and the percentile ranking is how we would compare nationally with every adult acute care hospital across the country.
And I noticed that in your digital numbers here, from 2018 to 2019, it doesn't appear to me we moved the mark very much.
Yeah.
But I have a hard time not understanding, but when you only move it like 1 point in a year, and then right now, out of the 9 or 10, you're 5 or more that you're not meeting your goals right now, so that would be a
Yeah.
concern to me.
So realize that the pool of data is enormous, because our pool of data includes every adult acute care hospital across the country. And when you look at that volume of data, moving the needle a small bit means you moved the needle a lot. And so even though on the numbers themselves, the raw number may not look like there's a large increase, as far as percentile ranking is concerned, it can shift you quite a bit.
I'll have to think about that for a
So,
minute.
and I'm happy to go deeper into it with you to show you. It's really complicated, but it's just a large, large pool of data.
Yeah, well, one of the things that I learned in my previous life is you need to measure the things that are really worth measuring.
Yep.
Give you an example. When I came on as the VP of Product Support at General Dynamics, we had 178 different IBM reports that we were using for 4 departments. And the guy I replaced was a Mensa guy. And he was literally going home every night, looking at these reports, be they daily, weekly, monthly, bi-monthly, whatever, and then coming in the next day and giving orders to the 4 directors. Well, I went to A&M, okay? So I'm not going to purport to be a Mensa person at all. So I took the first report for our Tech Pubs department home. And 3 weeks later, it was a weekly report. 3 weeks later, I'm still looking at that same report. And so I said, this isn't going to work. So I was going on a trip, and this is a long story, and I hate to belabor it, but
keep going.
I'll get to the point. I just had my secretary put a note on the 4 stacks of data. And you know what the note said? Please remove me from distribution. Real simple. You would have thought it would have been simple, but it wasn't, and I had 4 directors that were climbing the walls by the time I got back. So I sat down with the director of Tech Pubs because we were trying to move into the digital age. And we started at 7 in the morning. At 11, it was time for his lunch. We'd gone through 3 of his 87 reports, okay? And so I said, look, I'm going to get, I know you go to lunch at 11. I've got a lunch appointment at 12. So let's meet back here at 1. That's a 2-hour break. And in that period of time, I want you to tell me why I need you and all of this data. So when I get back, he's boxing all this stuff up. Long part to the story, we had every one of the directors push this thing down to the lowest level. We wound up with 31 reports, saved about $2 million annually just in the preparation, and we became more efficient. So I'm just kind of challenging you a little bit to make sure that we're measuring the things that we need to be doing better and not just measuring everything that comes along the road.
Yeah, it's a really important point. This survey actually comes to us from the Center for Medicare and Medicaid Services. We don't have an option in using it or not using it. It's what their researchers have determined is important for patients. And so this same exact survey is used in every hospital across the country.
Well, I guess, and I'll just finish by saying, at a 4, I would really expect that we're really going to churn a lot to get that better.
Yeah, and we work on it every single day. Again, remember, our performance level is already really high, so we perform in the top quartile nationally. And when that happens, to move a national average rate of improvement is very challenging. It's because we're not average. We're already above average. And so moving the needle at a higher level becomes harder and harder the better you get.
Then I find it hard, somewhere the scale has got to be wrong then, because 4 doesn't say you're above average. okay? It doesn't communicate that to me. 4 out of 10 doesn't say that you're above average. So something's wrong with, because the other thing I'll tell you is that when you continually have that low a mark, sometimes your people kind of quit trying. And I don't think that's the case here, but I've seen it. And so you need to be able to substantially be moving the mark. And so if it's 4, and 4 is never going to move, where are we?
Well, the one thing I'll say is, you know, that is the impetus behind this very dramatic effort with our providers, because that's the missing piece. And that has been, you know, to really have a tight partnership between our providers and all of our other staff on this stuff. And that is the reason for this substantial effort. This is not going to be a minor thing we're putting together here. It's really big. And the only thing I'll say from a if I may, sir, from a mathematical standpoint, you know, the number, so there's a difference between the number that we're moving in our current percentile rank, right? So our percentile rank is what it is. Our goal is to push that higher. We set the goal of moving particular dimensions at or greater than the national rate of improvement to try to take a high number and push it higher as our goal. But acknowledging that it's harder to move a high number. And some of our units actually that have had the most difficult results on an individual unit basis are the ones that are the high flyers, the ones that are sitting up in the 90 percentile plus range. They have obviously a tougher time pushing it yet higher on a consistent basis because there's a lot of noise in there too. So,
And I understand that, and also, since this is the first year you're doing this,
yes.
then, you know, there's room for us to figure this all out. I think the things you're doing look like they're the right things to be doing, but I just, in my business, you've got 2 warning lights. One says caution, caution, the other says warning, warning. Caution, caution is kind of where I think we are right now. Warning, warning says you're about to crash and, you know, give up the ghost. But I'm sure the board members will all do everything we can to help you, including cheerleading you.
Yeah, no, we need that. And, you know, I mean, we're trying to make it right for every patient, every day, every time, and we see 1.2 million encounters a year. So that's a lot of people that you're trying to get really functioning in the
And I
right
do
zone.
appreciate that, because I had 3,500 people working for me. It was the largest department of General Dynamics, and they were all over the world, so I kind of understand.
It's difficult.
You're moving a lot of information and trying to herd a whole bunch of people in a certain direction. I appreciate that.
Yeah, no, thank you for your comments. I appreciate it.
Reverend had a question.
Yes.
Not so much, well, I do have a question, but there's a comment on what Zim raised also, is that I think it might be, at some point, we take a break and go back and explain, because we have so many new board members, what the threshold, what the target, and what the stretch is.
Sure.
Because as you look at that
Yeah.
as an old board member, older than others, right, experience. Thank you, Charlie.
Thank you.
Thank you, Charlie. That we understand the 3, so as Zim looks at
Right.
that 3 and
Sure.
that 4, they may not understand where that is, and that could be higher than what
Yeah.
one appears, okay?
That's a great point.
Yeah. The other thing is, I want to go back to the certification program for a second. Now, if I understand correctly, JPS was selected as one of the hospitals to be a part of the pilot program. Okay. As a pilot program, then what we do, hopefully will work out all the kinks, but the program is something that is projected to be long-term?
Yes. Yes, this is round 1 for us building a patient experience certification program like this. And this will be the first of many. We will continue to have these after this particular first one is completed. And then we'll take a look back, really see what worked, what could we improve upon, and then we will continue to offer the program.
Okay.
Yes.
Because I would just hate for us to have gotten started in the program and then down the road,
Yeah.
it goes by the way.
Yeah. So we were the pilot 2 years ago. The program is still going strong and actually has grown. And so there are other hospitals that are within that now. We just happen to be on the front running of that.
How many hospitals are now involved?
It's big. There's over 50 or 60,000 members now within the program. Yes.
Yes, please.
I have a question, more comment from the survey itself. I know that it's a national survey. It's randomly selected of who receives the survey. I'm looking at the questions, and thank you for our meeting before and explaining all.
Sure.
It was
Yeah, no, my
fantastic.
pleasure.
I'm a data wonk, so this got me very excited. However, as I'm looking at the questions, wondering in the language barrier, because I know we've had issues with CMS before on language and how to translate those particular questions. Have y'all seen these questions in different languages and evaluated them from individuals on a
Yes.
3rd to 8th grade level?
We actually, yes, the surveys are available. Again, it's the same survey. We actually measure in Spanish. We measure 4 or 5 different languages. And we look a lot, particularly at those that we interpret for here at the hospital. Last year at JPS, we actually interpreted for 110 different languages. And of that group, though, there are 4 that are typically seen, English being one, Spanish, Vietnamese, and Arabic being the others. And so the survey currently is available in not some, but not all of those languages, so we survey as we can. And we actually review that data. And it's interesting, actually. It's a very interesting split. For the most part, our Spanish-speaking patients will rate us overall higher, but their communication levels are lower. And so we constantly look at how can we continue to bridge that gap.
Right.
Yeah, that's part of actually our diversity and inclusion program that Michelle Greenford spoke to you all about. We actually have a session in there on language and diversity when it comes to patient experience.
Perfect. And they're receiving this digitally? So
They
they're
receive it,
receiving-
it's a phone call. On
Phone
the
call,
inpatient side, it's a phone call. On the outpatient side, it's actually an email, and then if they do not respond to the email, it's a phone call.
Okay, perfect. Thank you.
My pleasure.
Any other questions, thoughts, Dorothy?
Oh, I did have, on Zim, when he was asking, even though we changed how we were looking at the different dimensions, there was we would be able to look at, compare it to what we had been doing in the past, right?
Yeah.
And that's what's up at the,
Yep,
is that the
that's-
year by dimension?
Yep, that's where you see, for instance, on the second column, let me look on here, because so the dimensions are the far left-hand column. The next column over is our year-end data from last year. And then the following, just to the right of that is our fiscal year total for this year. So what you can see is on care transitions, we've actually improved that dimension over last year. On cleanliness and quietness, we have improved that dimension. We have improved communication about, I'm sorry, that's the goal. Our fiscal year-to-date number is the next column over, so I apologize. So we have improved, starting with communication with meds, communication about pain, communication with doctors, communication with nurses, and discharge information, and the overall rating of the hospital. All of those dimensions have improved
And
this
what
year.
quartile will that put us in? That's the other part that we
You
used to
know,
get.
I would have to look. Alex Moore is back here. She actually runs all of our data
Right,
for us, so I
right.
asked her to be here. And Alex, I don't know if you have that information. You want to come on up?
Because that was kind of what we were looking at in the
Sure.
past too, was looking at that quartile that says, yeah, you improved, but where are you within that score? Zim, yeah.
So let me introduce Alex Moore, who's our program manager for patient experience. She actually pulls all of the data and gets into the nitty-gritty detail. She is absolutely phenomenal. She's been here for almost 4 years and has just really done a terrific job. So Dorothy, to answer your question, we will include the percentile ranking on the reports going
Right,
forward.
right.
But for today, we can at least provide
And
that
the only one I'm
information.
interested in is the care transition.
The care transition.
For this year, or last year versus
Yeah,
this
for last year,
So
where we're now.
Last year, we had 49.2% of our patients give us that top box answer, and compared nationally, that put us in the 36th percentile.
36 percentile, okay.
And this year, we have 46.6% of our patients who gave us that top box, and that puts us in the 24th percentile.
So
That one has gone down.
that one went down.
That one has gone down. But it's gone down in raw score too, so I
Okay.
misspoke at first.
Okay, I think that would show me a
Sure.
better picture.
It would.
Okay.
Sure.
All right, thank you.
And realize some of the dimensions are lower percentile rankings where some of them are higher, you know, so.
Right,
Right.
right. But that was how we were looking at it, and we'd have an overall score of them. And we were not moving, so we decided to look at them, pull an individual and say, okay, let's set a target here. Since we can't move them all, let's try to shift and go from 2, you know, to the kind of threshold saying, you know, we gotta meet this. And so that's kind of how those numbers came up. Okay. But it might help when you come back and educate the new board members. That makes a little bit more sense. Well, it does to me. It shows you how you look, and that's comparing you to other hospitals, because this is just to us, right here.
Right.
Okay?
I think the new initiatives that they're starting will help a lot.
Yeah.
Will. Okay.
We keep plugging away. It's
Absolutely.
a journey. It's a journey.
All righty.
All right, thank you very much.
I think I get to stay here, so.
You get to stay. The
I think I
PS.
get to stay and walk you through the next piece. Let's see. Let's see, how do you, oh, here's the clicker. Oh, no, that's the mic. Where's the, there was a clicker here, wasn't there?
That's a mine.
No.
She's gonna help you out back there.
You're gonna help me back there? Thanks, Laura, appreciate it. That's okay. It's okay.
She has 7 others at home, so.
All right. So, so it's my task now to walk us through our quality goal for this year, which was established as PSI 90. PSI 90 is a cumulative measure of basically some of the most common hospital-acquired conditions, avoidable hospital-acquired conditions that affect our patients in the hospital. It's a useful measure for a number of reasons. Its strengths are that it's, as I said, it covers most of the serious HACs that we see are hospital-acquired conditions. It's risk-adjusted and also weighted, so some of the more serious conditions that confront our patients are given greater weight, and others are given lesser weight. It's a pulled metric, so it's pulled by CMS based on coding data, and so it's basically pulled from every CMS participating healthcare organization in the country. The other reason it's useful to at least keep our eye on it is that it, although we're in a hiatus right now because they just updated the measure within the last year, and so we're all in a bit of a hiatus while we all adjust to this, to the new composition of this measure. It will eventually again be used to determine rates of reimbursement for healthcare organizations. So given its financial impact, it's worth keeping an eye on. This is how PSI 90 is measured. You can see the weights. So sepsis and respiratory failure in the postoperative setting are given the greatest weight. Venous thromboembolism, or blood clots in the legs and the lungs, are given also substantial weight, and then there are a variety of other conditions, and you can see their various weights. How are we doing? So far, we are, so our goal for the year was to bring our PSI 90 rate to that which would be expected given the severity of disease of patients that we're seeing for our organization. So a expected score would be 1.0. Our result in fiscal year 2018 was 1.1. We started off the year actually in positive territory, so you may remember that from the previous presentation. I wasn't here for that, but we had been in significant positive territory above, with a number that was significantly above our threshold in the first quarter, and now we're seeing some substantial improvement through a variety of efforts, which I'll share with you, and currently the number stands at 1.06. And you can see the various things that are moving in directions that we're either happy with or not happy with. on the column to your right. So if you have additional questions about that, we can go through them individually. This is our month-to-month result. So as you can see, we started off the year in not a very good place with the first 3 months of the fiscal year being significantly above our threshold rate. And now you can see we are improving. With the last 3 months have all been well within our goal range. What has accounted for this? The beginning of the process really is to get the coding right. There are a variety of inclusion and exclusion criteria for each of these measures. It's important to nail that down very precisely. That requires a lot of participation, not only by our health information team, but also providers, especially, to make sure that they're recording diagnoses accurately and both directly related to the condition, as well as to make sure that we're capturing appropriate exclusion criteria. This is very important, of course, because the real goal of any measure that we have around the hospital, particularly to Mr. Zimmerman's point from earlier, is to make sure that whatever we're measuring is actionable, so that we have measures that we can take to our providers and say, hey, we've got some opportunities for improvement in these areas. The data is reliable, the data is good, and if we make these changes, we should be able to move the data into a better place. So the first thing is to use this coding process to get good data, and then from there to move on to improvement projects that will ultimately result in improved outcomes for our patients, which is ultimately the goal. Yes, sir.
So volume-wise, I know it's a rate, but were more patients being seen in October or?
No. I mean, no, it's not seasonal at all. No, we have, massive volume around here all the time. I mean, there are minor month-to-month variations, but not enough to change it in this way. And our surgical volumes have actually, if there's one thing about this measure that could be knocked on a little bit, is that it's heavily surgical. There's a lot of, if I can go back, there's a lot of surgical stuff in here: post-operative sepsis, post-operative respiratory failure, perioperative VTE, post-procedural pneumothorax, perioperative hemorrhage and hematomas. There's a lot of surgical stuff built in here, and our surgical volumes month to month have actually only been growing.
Right,
So,
okay.
yeah. So,
And I know a lot of it would be resident dependent also, or not?
in
Say that
terms of
again.
what?
I didn't.
Would a lot of this be resident dependent also?
Well, I mean, residents are involved in a lot of the care of the patients across the board, but in terms of getting, I would say, in terms of getting this kind of improvement, probably our providers have been more critical in driving this because they're taking the ownership, and and if we need the residents to do something in terms of their documentation or coding, that's usually coming from the providers down to them, I must say. So I think that this has been a little bit more provider-driven than resident-driven, at least in terms of seeing these improvements. What I would say to you is, I don't think that overall that we have had and I know I can ask you any sort of granular question about the kinds of cases that we've been seeing, but I would say that the actual outcomes of our patients are not dramatically different from the first quarter to the second quarter. So I think most of this improvement so far has been in terms of clinical documentation and coding.
Okay.
So once we have that part of the process dealt with, then we can go from there to say, how do we move whichever elements of this we want to move in a productive way. I mean, there are some clear opportunities for improvement. Back on this slide, you can see that, for example, postoperative perioperative venous thromboembolism is still significantly above what we would want to see for our patients, and didn't even move in the correct direction fiscal 18 to fiscal 19. So that's an area where we'd, of course, like to see improvement. So you can go down into the various elements of this and say, look, we probably have opportunities here or there. The sepsis rate, at least in part, is a coding issue at this point, just to be fully clear. So some of this, we're still trying to get to data that is truly actionable. So I think that, in this first year of this goal, this has been really the heavy lift, is to make sure that we're looking at good data. But ultimately, it'll benefit us to get to that, because eventually the federal government's going to be looking at this again in terms of determining how much they want to pay us, so. Okay. So just to sort of summarize, so we're still in the early phase of improving documentation and coding. There are some specific quality of care things, particularly surrounding VTE going on, venous thromboembolism. And, you know, I would say that system engagement's built into the whole thing, simply because there's a high level of engagement and ownership around a lot of these measures at this point in time. Do you have any questions for me?
Zim, you're thinking.
No,
That,
you'll know when I've got a question.
But I have a question.
Okay.
Okay, so when you say coding, is it coding from our side? Is it an
Coding from
issue
our
with,
side.
is it an issue with the software, or is it an issue with just in-person coding?
No,
Or-
so our coders are really good. That's not a problem. The biggest issue actually is putting down the diagnoses that are appropriate for the patient at the appropriate time. So I would say, I perhaps was a little bit imprecise in saying coding. It's really a bigger opportunity in clinical documentation,
Okay.
okay?
Awesome.
But that's what drives coding, so,
Yep. Thank you.
of course.
any comments? Thoughts? All righty.
All righty.
Thanks, Rob.
Rob, thank you very much.
My pleasure.
Laura,
Thank you.
I don't have anything else for open session, so we would take about 5 minutes and we'll reconvene in closed session pursuant to